you can see all the vitals, you can see all the parameters, and take action and help somebody at primary healthcare centers actually work. You could also call in other doctors if you want to. So you could have mobile iPad connectivity by which live you could call doctors. So as you can see, one of them is driving, but they can actually look at it, look at the case, all the data is there. So this is running as a pilot, and we are Timpur District Hospital, and we continue to try to grow this. So this is something definitely we can also partner with and talk about. I heard the person from Vodafone also talk about networks. So it's a great collaboration. With that, I come to the end of my presentation. So let me just summarize the last slide. So what we like to really do. What is our summary of an approach to a healthier world? It is basically focus on outcomes and advocacy, public-private partnerships, have the right products, help in project management. We also have skills development programs which we can work on and provide really good service and support. So this is what is our summary for approach to a healthier world. We are basically focused on mental health and care, oncology, radiology, and critical care as first set of areas, critical areas that we want to actually work on. We've got some national and international recognitions on this, CII Awards, Innovation Awards, and we are committed to quality healthcare solutions for people. Thank you very much for your hearing. Thank you for inviting me here. Thank you for the patient hearing.
Thank you very much, Mr. Shyam, Prasad, Rajan. A round of applause for this very interactive presentation. You can ask questions offline to Mr. Rajan.
India, GE Healthcare is 18 billion P&L of GE. We employ about 21,000 employees worldwide, and around 18 plus dollars per year is invested in R&D for things like multiple areas of healthcare, medical imaging, life sciences, and so on. We have a broad set of solutions in the spaces of healthcare systems, healthcare IT, global services, life sciences, and so on. Healthcare systems is the one that most of us are familiar with in terms of equipment that we interact with, like X-rays and CTs and MRs and so on. Having talked about that, I would like to quickly come in the paucity of time to what we do in India from a GE Healthcare standpoint. So this is our center in Bangalore. We are based in John W. Welch Technology Center in Bangalore. And what we've been trying to do over the last 5 or 6 years is to create a kind of world-class affordable healthcare COE, a center of excellence. We have around a 21-year history. We have over 1550 employees working, and we've delivered over 100 products over the last 6 or 7, 10 years of us having been there. So with that, let me get into this whole concept and this whole topic of affordable healthcare. And what are some of the challenges, what are some of the needs, and how have we tried to sort of really work on those needs, and what are some of the things that we have done to ensure that we can take these solutions and provide access to people all over. So the need. One good thing today is I don't have to talk too much about the need, because the whole morning session we've been hearing about the need of how there is access limitations in the rural areas and what is exactly needed. So I won't spend too much time on it, but I'll just go through. We all know there are 3 kinds of India. There is an India which is living in the metros, there is an India which is in tier 2 and tier 3 towns, and then there is an India which is in the villages. We understand the India in the metros and maybe the tier 2s, but we don't have much of an understanding. It's unserved, underserved at the rural areas. So that's one piece. The second is, of course, disease patterns. There is a big shift from infectious disease to non-communicable diseases, especially in the areas of mental health and care, in the areas of cardiology, oncology, and so on. And of course, certain other issues such as skilled manpower constraints, cost of capital being quite high, healthcare expenditure is high, and also a little bit of ecosystem behavior, which we'll delve into as we go a little bit. So these are some of this is the environment in which we are working. Now all of us understand this, and we've all been involved in this in some way or the other, in parts of it, but this is the environment, very unique needs. The second thing, which is very important, which has been one of our learnings, is in many cases when we are talking about affordable healthcare solutions, we end up going into what we call the non-consumption space. So what I mean by that is, if you go to a primary healthcare center in many parts of rural India, you'll find that treatment is still delivered using a 200 watt light bulb. Now, if we were to make a warmer, however low cost it might be and however efficient it might be, we are competing with the light bulb in many cases. Similarly, phototherapy, we may be competing with sunlight. If it's resuscitation, we are competing with manual bag and mask. So therefore, that's also a key challenge. It's needed. But when you start competing in the non-consumption space of healthcare products, then you have to change the way you actually think and the way you actually innovate. So the third one, of course, different needs for different segments. Again, I won't delve into this too much. PHCs, CHCs, district hospitals, they are tired, they have different needs, and they need to tailor equipment for those various needs. So, who wants an affordable solution? Not many people, I think. But what we consider it challenge. It is challenging to work in the affordable healthcare space, but we also consider it an opportunity. So the next part of the presentation, let me take you through how to innovate for a need as varied and disparate as what I showed you in the past few slides. So if you look at the innovation methodology, traditionally, innovation has happened as we see on the graph on the left. Now, on the left, what you see is the traditional features and price axis. You have a product which is highly featured, expensive, and if you want to make it low cost, then what you end up doing is reducing features. You keep reducing features until such time you come to a particular cost position, and that is how traditionally innovation has happened in the low cost markets. Our learning over the last 5-6 years has been that that does not completely work. That is important. You need to reduce and create just what's needed, but you also need to innovate on a multiple number of other axes, which is on the right. So for example, you might have to innovate a product such that it's rugged and reliable, so that it's able to make it to all these areas. It might need to be modularly services, so that you don't have to send a field engineer every time to do something. You might need it to be totally user-friendly because you do not want to intimidate your users who are already maybe not as well trained as others. You want to have no consumables. Maybe portability, because spaces are small and you might want your equipment to be portable, and the same room may be used as different things during different parts of the day. Protracted power. What happens if the power goes off? Can the warmer shut off? Or should we be providing some kind of an alarm so that the warmer is actually saying that, hey, the power has gone down, and when the power comes back on, the warmer comes back graciously. In the normal case, if the power fluctuates, let's say at 400 volts, which we have seen in certain parts, the power system will just go off, and then that warmer would never be used and it will become unusable. So our take has been, you cannot just innovate on the features and price axis, but you've got to start innovating on a new set of axes, which is what I've shown on the right, and it has to focus on sustainability. So that is what we're basically focused on. So basically what we try to do is lower the cost by around 40% at least, but also be very careful about the total cost of ownership, reduce that by around 30%. Try to make the life 5x smaller. Try to make it repairable, replaceable parts. Very user-friendly so that you need very little skills to actually operate. And the three circles there, make it relevant, co-create it with the people. So if there's an ASHA worker, co-create with them. If there's a midwife, co-create with them. And co-locate R&D and manufacturing. That's extremely important. So that the designs that we do, we can actually manufacture ourselves. And that gives us a lot of localization benefits and cost benefits as well. So this is how we have sort of tried to design our products for the emerging markets. And then a iterate, build, measure, learn. This is an example of a warmer. The warmer is sitting outside, but when it started off about 3 years or 4 years back, it looked like a bathtub on the left. And then it's gone to multiple iterations across primary healthcare centers, across customers to see how to actually bring it to the form it is in right now. The other thing is also made in India. I talked about manufacturing. We have 3 manufacturing facilities, and we try to make sure that we co-create this with our suppliers, our partners, our vendors. And I really love what the Additional Secretary in the morning said about how nobody can make it happen on their own. It has to happen with an ecosystem which is in place, and that is suppliers, customers, co-creation, neonatologists, medical institutions, medical device manufacturers, and so on. So this is some of our affordable care portfolio. We have released about 28 products into the field in the affordable care area. We have kept it very clean into clinical areas. So there are 4 clinical areas in which we focus: mother and child, cardiology, radiology, and critical care. So these are some of the products that we have brought out. What I'll do is I'll give you a quick example. One of them is called the Revolution ACT. This is a CT which we launched about 4 weeks back. Again, the same kind of thing, 40% lower cost, much better ROIs, but at the same time, the best technology. So low cost is not low technology. Sometimes it's mistaken for low technology. Low cost, most of the time, is high technology. You have to innovate a lot to get something low cost without compromising on clinical efficacy. The CT is an example of that. And technology differentiation, economic viability, and answering kind of an unmet need. These are the three things that we actually focus on without compromising clinical efficacy. So that's the Revolution ACT. Another product from the oncology space, a Discovery IQ, what we call a PET CT. Again, there's 2.5 million incidents of cancer in India. We need to have an affordable PET CT, and this is an answer to that. Again, low cost. The first time in the history of PET CTs that we have made a field replaceable number of rings. So you could start off with a 2-ring configuration if your patient flow is low, and then as your patient flow goes up or ROI goes up, you could upgrade it to a 4-ring or a 5-ring on the field without any siting requirements to be done. So first time we're doing that. A lot of innovations on the reconstruction, on the image processing, a lot of great algorithms that we've actually worked on to make this Discovery IQ PET CT doing extremely well. Again, so that's what we call as you can start with what we call access and upgrade yourself to an excellent or essential or excellent, and all this can be upgraded on the field. This one I already talked about a little bit, but normally it's a light bulb. From there we make some kind of a compromise, which is messy, but based on a lot of innovation, you see the product outside. This is the Lullaby Warmer Prime. Now, for example, one feature I would like to highlight here. Now, one of the things we used to have a huge issue with as far as warmers go is the temperature probe. The temperature probe keeps breaking in our premium warmers. Now, in this warmer, what we said was based on customer feedback, we said we'll make the temperature probe unbreakable. So the temperature probe is actually made of Kevlar. So Kevlar is what's used for making bulletproof vests or coating fighter airplanes. So this probe can never be broken while cleaning. Now, this probe is actually more expensive than the probe that comes on our premium warmers. So, in many cases, low cost doesn't mean that you make everything cheaper. It is that you need to figure out what is exactly needed and what are those pieces that you need to make cheaper, and some of it may actually become more expensive. Which is what, again, is one of our learnings over the last few years of doing this development. Okay. Want to quickly take you to a tele-ICU example in critical care. One of the things is that lack of intensivist skills in the rural areas, in even tier 2, tier 3 towns. So therefore, what we have is a tele-monitoring of ICUs. So you could have a hub, and you could have all these spokes. You can actually monitor it. Again, we are working very closely with the government of Karnataka on this. We will show you some examples. I heard some talk about tele-medicine. Tele-ICU monitoring is great, and then we're looking at seeing how we can take it to other places. So all of our equipment, all the vital parameters of the patient, along with facial expressions, using streaming technology, is brought to the hub, where doctors can actually collaborate and do things. So I'll show you an example of this as we go. Some examples in terms of partnerships. Maharashtra, we have a radiology partnership. In Tamil Nadu, we have done Uttar Pradesh, we have had some primary healthcare centers where we have put in warmers. We have done close to 70 PPVs in about 12 states. And with that, I'll just end this with a short video of the tele-ICU. So let me just play this for about 30 seconds and then we can end this. So this is the Karnataka government site. The volume is down, they speak in Kannada. I thought I was going to speak in English and translate it. So this is, if you go to the Karnataka Mobile One site, you'll find the solution. So this solution actually running in the Tukur district hospital. The district hospital where the tele-ICU solution is there. This is the Columbia, it's called GE Centricity Tele-ICU. And it is connected to the to Columbia Asia in Bangalore. This person is the surgeon there, is the cardiologist and the intensivist. He's actually talking to the nurse. This is and what happens is they can actually collaborate live, give instructions to the nurse, take instructions to the A&M. The A&M has got speakers, so extremely well. The technology is pretty mature and good cameras. We keep continuing to make progress on this as we go forward. So